Clinical chemistry, renal function. So the urinary system has several different functions: urine formation, fluid and electrolyte balance, the regulation of acid-base balance, excretion of waste products of protein metabolism, excretion of drugs and toxins, and secretion of hormones. This is a basic overview of the urinary system. It's a pretty simplistic system where you have kidneys, ureters, the urinary bladder, and urethra. So the kidneys are where urine is formed. The ureter is a tube that connects the kidneys to the urinary bladder. The bladder is where urine is going to be stored until it's time to urinate, and the urethra is the final passage through which urine is going to be released from the body. Urine is sterile. Sterile meaning that it's sterile when it's within the body. As soon as urine passes through the urethra, it does become contaminated with bacteria. Urine is a clear fluid that has a slightly acidic pH. It's discharged through the urea, and micturition is the process of urination. The average daily output of urine is 500 to 1500 mils. Anuria is less than 100 mils per day. Oliguria is less than 400 mils per day, and polyuria is greater than 2 liters per day. The basic anatomy, as I just went over, the kidneys are paired bean-shaped organs that are located retroperitoneally on either side of the spinal column. So they're easily accessible from the back side of the body. There are two regions, or two main regions of the kidney: the cortex, which is the outer region, and the medulla, which is the inner region. There are bilateral ureters, which are thick-walled canals that connect the kidneys to the bladder. And then nephrons. Nephrons are the functional units of the kidneys, and that's going to be responsible for producing urine. Approximately 1 million are found in each kidney. So this is a picture of a typical kidney. So here you can see this outer region is the cortex. The inner region is the medulla. There are renal pyramids in here, and the renal pyramids, if we blow one up, contain the nephrons. The nephrons are tubules where urine is going to be formed on the inside. Anything that is not meant to be passed out the body through the urine is going to be reabsorbed by the blood vessels that surround those nephron tubules. Once urine is formed, it's going to pass through into the renal pelvis and eventually down the ureter to be stored in the urinary bladder. When we talk about the basic parts of a nephron, first we have the glomerulus. The glomerulus is a capillary tuft that's surrounded by an expanded end of a renal tubule. Here's a picture that I'm going to go back and forth and keep referencing, but we have the blood vessel and the afferent blood vessel. Afferent with an A goes into the nephron, and this is going to be the glomerulus here. So the glomerulus is a ball of capillaries. These capillaries are thousands of times more permeable than your normal blood capillaries in your body. So all sorts of substances are going to be released, and they fall out of the bloodstream in this location down their concentration gradient. They're going to be captured by this right here, which is called the Bowman's capsule. So the Bowman's capsule is responsible for capturing all of the substances that are released from the glomerulus. The proximal convoluted tubule is located in the cortex, and this is a picture of the proximal convoluted tubule. Convoluted just means twisted. So here is the proximal convoluted tubule, and it's proximal because it's close to the point or the origin of where the glomerular filtrate is produced. The loop of Henle comprises descending and ascending limbs. So the loop of Henle is down here. So first we have the descending limb of the loop of Henle, and then the ascending limb of the loop of Henle. The distal convoluted tubule is located in the cortex. So here is the distal convoluted tubule, and that is going to attach to the collecting duct. And multiple distal convoluted tubules are going to be connected to this collecting duct, and it's going to put all of its urine inside of that collecting duct. There are three basic processes, or basic renal processes: glomerular filtration, tubular reabsorption, and tubular secretion. Glomerular filtration is talking about when you have the glomerulus and all of those substances leak out of the glomerulus down their concentration gradient. That is going to be glomerular filtration. Proteins and cells are too large to fit through the capillary walls. So any substances that are smaller than that will be able to leak out into the urine. So just to kind of reiterate here, the good stuff is in the blood. It's going to leak out and then be captured by the glomerulus. It's then the job of this nephron tubule to suck back up the substances that we still need in the body. And anything that's left by the time it gets to the collecting duct is going to pass out of the body as urine. Glomerulus filters incoming blood. The factors facilitating filtration include unusually high pressure in the glomerular capillaries, semi-permeable glomerular basement membrane, and the negative charge of the basement membrane. Of the 1,200 to 1,500 mils of blood received by the kidneys, the glomerulus filters out 125 to 130 mils of protein-free, cell-free fluid called the glomerular filtrate. The glomerular filtration rate is the volume of blood that's filtered per minute. And that is calculated, or the estimated GFR is calculated to serve as a basis for renal function. The proximal tubule does both reabsorption and secretion, and there is a difference between reabsorption and secretion. Reabsorption is talking about taking substances from the urine, so from the inside of the nephron tubule, and putting them back into the blood. And those substances that it would reabsorb are going to be still needed in the body, so they're nutrients that the body needs. Tubular secretion is talking about putting substances from the blood into the urine. Now, the majority of that happens in the glomerulus, so substances are going to be filtered out in the glomerulus, but sometimes additional substances need to be forced into the urine. So toxins, some type of bacterial metabolites, and other types of substances need to be forcibly put into the urine, and that can happen during tubular secretion. So in the proximal convoluted tubule, it's responsible for reabsorbing most of the nutrients, and then also secretion can happen in that location, and it secretes products of metabolism. The loop of Henle is going to aid in the reabsorption of water, sodium, and chloride, and different parts of the tubule are going to be responsible for the reabsorption of different substances. The descending limb is predominantly water, while the ascending limb is predominantly ions such as sodium and chloride. The distal convoluted tubule adjusts for electrolyte and acid-base homeostasis through the hormonal control of the antidiuretic hormone and aldosterone. Now, though we will spend some time talking about hormones when we get to endocrinology, I do want to take a minute to talk about these two hormones now. The antidiuretic hormone, or ADH, is released by the posterior pituitary. If you remember from basic anatomy, the pituitary gland is inside of the brain, and it consists of an anterior pituitary, a posterior pituitary, and they're connected by the infundibulum. The posterior pituitary will release antidiuretic hormone in response to a decrease in blood pressure. So when blood pressure drops, that means that there's not enough fluid in the bloodstream. In order to increase the amount of fluid in the bloodstream, we need to increase the volume of blood. And the easiest way to do that is by putting more water into the blood. So antidiuretic hormone is going to act on the distal tubule and the collecting duct, and it's going to increase the amount of reabsorption of water. More water gets back into the blood, that increases our blood volume and increases our blood pressure. Aldosterone works pretty similarly. Aldosterone doesn't come from the pituitary. This one comes from the adrenal cortex. So the adrenal glands sit right on top of the kidneys, and they have two different distinct parts to them, the adrenal cortex and the adrenal medulla. And each part produces different hormones entirely. The adrenal cortex releases aldosterone, again in response to a decrease in blood pressure. Aldosterone is going to act on the distal tubule to increase the amount of sodium reabsorption, and that is going to indirectly cause more water reabsorption as well, so that it's going to ultimately increase the blood pressure. The collecting duct is the final site for concentrating or diluting the urine. It controls the reabsorption of water, sodium chloride, and urea. So urea is readily filtered by the glomerulus and reabsorbed in the collecting duct. Creatinine is also readily filtered by the glomerulus, but it is not reabsorbed by the tubules. Uric acid is readily filtered by the glomerulus, but it undergoes a complex cycle of reabsorption and secretion as it goes through the nephron. Water balance. So increased plasma osmolality or decreased intravascular volume stimulates the secretion of ADH from the posterior pituitary. If we look at that term intervascular, inter means inside of, vascular is talking about the blood vessel. So if the blood vessel volume decreases, that's going to stimulate the secretion of ADH, and we just talked about that whole process. ADH increases the permeability of the distal convoluted tubules and collecting ducts to water, causing an increase in water reabsorption. So that's just reiterating what I just went through. The electrolyte balance, sodium is controlled primarily by the renin-angiotensin-aldosterone system. So I'm going to click forward just to show you a diagram of this. So renin is going to be released by the kidneys in response to a decrease in blood pressure. So if we have low blood pressure, the kidneys are going to release renin. Renin is going to stimulate the release of angiotensin from the liver. Angiotensin is then going to be converted to angiotensin 1. Angiotensin 1 is going to be converted to angiotensin 2 by this enzyme ACE, and ACE is angiotensin converting enzyme. Once it's angiotensin 2, that's going to increase the release of aldosterone from the adrenal gland. And aldosterone is going to cause an increase in sodium retention, which indirectly causes an increase in water retention, and that's going to increase the blood pressure back up to normal. For patients who have high blood pressure, we want to stop this system from happening, because if you already have high blood pressure, you really don't want higher blood pressure. So we have drugs called ACE inhibitors that block the enzyme ACE, and that prevents the conversion of angiotensin 1 to angiotensin 2, which ultimately will decrease our blood pressure or keep the blood pressure a little bit lower. Potassium is reabsorbed and excreted by the distal convoluted tubule and collecting ducts. Excretion is controlled by aldosterone. Chloride kind of follows sodium, so it's passively reabsorbed as a counterion when sodium is reabsorbed. Phosphate, calcium, and magnesium are also reabsorbed. As far as acid-base balance, the regeneration of bicarbonate ions, excretion of metabolic acids, reaction with ammonia, and reaction with monohydrogen phosphate all affect the pH of the blood. The kidneys do produce their own hormones. We already talked about renin, which renin catalyzes the synthesis of angiotensin. The kidneys also produce erythropoietin, which is responsible for red blood cell production. So it acts on erythroid progenitor cells in the bone marrow to increase the number of red blood cells. It also plays a role in vitamin D synthesis. So 1,25-dihydroxyvitamin D3 is the active form of vitamin D, and it determines phosphate and calcium balance and bone calcification. Prostaglandins are also produced by the kidney. They increase renal blood flow, sodium and water excretion, and renin release. They oppose renal vasoconstriction. Vasoconstriction is talking about a constriction of the blood vessels. So they would oppose this. Analytical procedures evaluate clearance measurements. So clearance is the rate at which creatinine and urine are removed from the blood into the urine. Creatinine is endogenous metabolic product synthesized at a constant rate and cleared only by glomerular filtration. Creatinine clearance rate is the standard lab method to determine glomerular filtration rate. So if you have a high creatinine clearance rate, that means that creatinine readily passes into the urine, then you have a decent glomerular filtration rate. Estimated glomerular filtration rate is used to predict the GFR. It's based on serum creatinine, age, body size, gender, and race, and does not require urine collection. The Cockcroft-Gault formula is one of the first formulas used to estimate GFR. Urea doesn't really provide full clearance assessment and is no longer widely used. Cystatin C is a low molecular weight protein that's produced by nucleated cells. Levels remain stable if kidney function is normal. There's also biologic variation that happens. It's the random fluctuation around homeostatic setting point, either within an individual or between individuals. For creatinine, within subject variation is less than between subject variation, making it more helpful in monitoring an individual. So if we take creatinine levels on one patient multiple times, we can compare those and get a better idea of the overall health status of that patient. Beta-2 microglobulin is used to clinically assess renal tubular function in renal transplant patients with elevated levels indicating organ rejection. Blood and urine beta-2 microglobulin tests may be ordered to evaluate kidney damage and to distinguish between disorders that affect glomeruli and renal tubules. Myoglobin clearance has been proposed as an effective early indicator of myoglobin-induced acute renal failure. Blood levels of myoglobin can rise very quickly with severe muscle injury or rhabdomyolysis. Microalbumin, now called albuminuria. Urine microalbumin measurement is important in management of patients with diabetes mellitus who are at risk for nephropathy. So patients with diabetes mellitus have increased glucose, and that glucose can do a lot of damage to the nephron tubules. So if they have uncontrolled glucose in the blood, then they can be at higher risk for nephropathy. In later phases of nephropathy, increased glomerular capillary permeability allows small amounts of albumin to pass into the urine. For a 24-hour urine collection, 30 to 300 milligrams of albumin is diagnostic of albuminuria. Neutrophil gelatinase-associated lipocalin. NGAL is a 25 kilodalton protein that's expressed by neutrophils and epithelial cells, including of the proximal tubule. Elevated within 2 to 6 hours of acute kidney injury, and it's measured in plasma and urine. Urinary NGAL excretion may not be specific to AKI, but it is useful in diagnosis. Urinalysis is also another common analytical procedure. It permits a detailed, in-depth assessment of renal status with an easily obtained specimen. It serves as a quick indicator of glucose status and hepatic biliary function. Routine analysis includes evaluation of physical characteristics, chemical analyses, and microscopic examination of the sediment. Physical tests include color, odor, turbidity, volume, and specific gravity and pH. Chemical tests evaluate the presence of glucose, ketones, and protein, nitrate, leukocyte esterase, and bilirubin, urobilinogen, and blood. Microscopic tests can include cellular elements, including red blood cells or white blood cells, bacteria, and miscellaneous elements. Various casts and protein-based sediment can be evaluated as well. Talking a little bit more about the pathophysiology, acute glomerular nephritis is talking about large inflamed glomeruli with a decreased capillary lumen. Rapid onset of hematuria and proteinuria. Hematuria is talking about blood in the urine, and proteinuria is talking about protein in the urine. If suddenly you have a rapid onset of blood and protein in the urine, we would classify that as acute glomerular nephritis. Chronic glomerular nephritis is talking about glomerular scarring and eventual loss of function of the nephrons. So gradual development of uremia may be the first sign. Nephrotic syndrome is associated with massive proteinuria, so protein in the urine, hypoalbuminemia, which means not enough albumin production, edema, which is swelling, hyperlipidemia, which is too much fats in the serum, and lipiduria, fats in the urine. There's also tubular diseases, which results in a decreased excretion, reabsorption of certain substances, or reduced concentrating capability. Renal tubular acidosis, which is a disorder that affects the acid-base balance. Other types of tubular diseases include polycystic kidney disease, where multiple cysts can start to appear in the nephron tubules. Urinary tract infection. Infection is either in the kidneys or the urinary bladder, and obstruction is in the upper or lower tract. And renal calculi or kidney stones can be formed from a combination of various crystallized substances. Renal failure can be classified as acute or chronic. Acute renal failure is sudden, sharp decline in renal function. This is usually due to some traumatic event. So suddenly we have damage to the kidneys, there's sudden blood loss, there is a severe burn that happens. So something dramatic suddenly happens to cause renal failure. Chronic renal failure is a gradual decline in renal function over time. Renal hypertension is caused by a decreased perfusion to the kidney. So hypertension is talking about high blood pressure, and that's caused by decreased perfusion to the kidney or decreased amount of blood going to the kidney. Therapy of acute renal failure includes dialysis. So dialysis is the removal of waste from blood by external synthetic membrane. Dialysis can take place in the blood vessel through a port, or it can also, there's intra-abdominal dialysis. There's lots of different types of dialysis that exist. Therapy of end-stage renal disease is dialysis and eventually transplantation. This final table is just a list and a summary of the diagnostic test of renal function and its usefulness. So take some time to review this table.